So in the early part of the postoperative setting, when they're in the PACU, we need to assess the patient for drowsiness and lethargy secondary to anesthesia and wakening up from the anesthesia coming out from it. So we're going to look at their neurologic status and kind of compare it to where they were at preoperatively. We're going to assess their pupils to see if they're reactive. Are they pinpoint or are they dilated? This could definitely be an indicator that they still got a little bit anesthesia left in their system. We might check their gag reflex, definitely before we give them any kind of ice chips or any types of fluids. We're going to ask them to cough. We might take a tongue depressor and put it back to the part of their tongue to see if they're going to elicit a gag reflex or a response. We're also going to check their upper and their lower extremities. Like I said, comparing to baseline, are they moving everything well, strong, into command? Even if our patients are not diabetic in the postoperative setting, we are going to monitor their blood glucose. Sometimes it might just be a couple times, and other times we might do it every 6 hours or around the clock. Evidence has found that if we can keep patients' blood sugars well controlled, even if they're not diabetic, throughout the perioperative setting, we can decrease the risk of surgical infections and improve healing times, and also decrease morbidity and mortality and length of hospital stay. So elimination status, especially urination, it's going to take hours, sometimes between 6 to 8 hours for them to regain voluntary control of their urination. So a lot of these patients will have a catheter when they come back from the OR. Some patients who have a very minor or shortened surgical procedure may not have a catheter. So we need to be evaluating their urine output, whether it's with a catheter or without. We're also going to be monitoring for the early stages of maybe some discomfort and pain. Like we said, a lot of times anesthesia is still within the system, or if they've had a regional block, they might still not have as much discomfort. But we're still going to assess for it, asking these patients if they're in pain, how are they feeling, and are there any objective indications that they're having pain. So later in the postoperative period, if this is where the PACU actually transitions the patient to a surgical floor, another standardized checklist handoff is going to occur because, like we said, we want there to be good communication throughout the perioperative period to improve safety and to improve the quality of the care and not to forget anything. Again, we're going to be doing vital signs probably pretty frequently, at least every 15 minutes to 30 minutes for the first couple of hours, and then we might transition it to every 2 to every 4. And then once they're out of this postoperative period for the first 24 hours, we might transition them to like every 8 hours, every 4 hours, depending on what is the standards of the floor they're on. We're also going to continue to evaluate their airway, their breathing. We're going to look at their respiratory rate. What do their lungs sound like? How is their work of breathing? What does their color look like? And we're also going to look at their circulation, their blood pressure, their heart rate, their pulses, their peripheral pulses, and their color. So depending on the degree or the length of surgery, if it's major versus minor, some of these patients may continue intravenous fluids until the next day. Sometimes they won't even stop the IV fluids until these patients are able to take PO liquids effectively enough to maintain their hydration status. So if a physician does write an order to saline lock or cap an IV once they're taking clears, then you would just take off the IV fluids, you'd flush the IV, and you'd keep it open and you'd keep it patent in the event that something happens and we would need it at some point later. So if a patient does come back with a Foley catheter, it needs to be removed as soon as possible until we feel that it's safe that the patient could potentially be urinating on their own. So once we take out a catheter, the patient really needs to be urinating within 8 hours. There's a lot of standards on surgical floors that if patients don't urinate within 6 hours, we need to be assessing them for urinary retention. And so we know So one of the best ways to assess for urinary retention is to talk to the patient. How are you feeling? And we're also going to be assessing for bladder distension. Where is their bladder? Do you feel like you need to go, but you can't? And in these patients, if we are able to identify that they have bladder distension and that they have retention, we might have to do an intermittent catheter to alleviate their pressure. Or we might try some different things as far as like getting them up and walking them to the restroom, letting the water run to see if they can urinate on their own. We're also going to be looking at their dressings. Typical dressings that come back from the OR need to stay in place for 24 hours. We're going to evaluate them for bleeding. Usually, even if there's some bleeding, we're just going to reinforce the dressing with an additional gauze or ABD bandage. We're not going to take it down unless we need to. So there's definitely a difference between overt bleeding, hemorrhaging, versus just a little bit of slight drainage. Okay? So we're going to look at the wound care orders for these patients. It could be anywhere from changing it daily to changing it twice a day. And so usually that's pretty specific by the surgeon, what we're going to do. And we're also going to look at drains. A lot of these patients that come out with more extensive surgery, some of your orthopedic patients, a lot of your thoracic patients, gastrointestinal patients, they're going to have drains. They might have hemivec drains, or they might have JP drains that are going to decrease some of the edema and the fluid that accumulates around the incision site to increase healing. So this is an example of the difference between bleeding, which is an emergent situation where we would be contacting the physician, versus just a little bit of blood that we might be keeping an eye on that might be normal. So in the postoperative period, also in the late, we are going to continue to prevent complications that would lengthen the stay of these patients. We're going to focus on their respiratory, because that's what we do. We focus on ABCs. We're going to monitor their respiratory status, assess their respiratory status. They might need a little bit of oxygen. Typically, these patients might come back on a couple liters, 2 liters of a nasal cannula. We're going to encourage them to deep breathe and cough, usually every 1 to 2 hours. And if these patients aren't able to turn or move on their own, we're going to have to do that for them. We're going to get them up as soon as we're allowed, at least getting them up to the chair or getting them up and walking them to the restroom. We're going to have them use their incentive spirometer every 1 to 2 hours while awake in the beginning. We might transition to something more spread out, but in the beginning, we want to prevent atelectasis and pneumonia. And if indicated, we might use some breathing treatments to kind of help open up their bronchioles and their airways so that coughing and use of the incentive spirometer can be potentiated. And if all else fails and these patients cannot clear their airway, if they're frail, if their cough is ineffective, we're going to NT-section them like you worked on in lab last week. Cardiovascular, because we want to prevent any blood clots, we are going to get these patients up and move them early and frequently. They might have compression stockings on that's going to increase venous return and reduce swelling. They're going to have sequential compression devices, as that's going to increase their circulation again and prevent venous stasis. We're going to encourage our patients to do active range of motion exercises in their lower extremities to improve their circulation, decrease their swelling, and to alleviate some stiffness and discomfort. We're going to make sure our patients drink adequate amounts of fluid, at least 1,400 to 1,500 mLs per day. And then some of these patients might be on anticoagulants or preventative blood thinners like heparin. And these injections are going to be sub-Q, so they're going to be in the adipose tissue. So the picture on the left is an example of heparin, which is something that patients may get 2 to 3 times a day while they're in the hospital. It just keeps their blood thin enough so that they don't have to worry about maybe accumulating a blood clot. And then the picture on the right is just an example of anti-embolism hose that keeps the blood circulating and it keeps the compression as far as for swelling. And then the wraps around them are the SCDs, which also improves circulations and increases venous return. So in the postoperative setting later as well, we're also going to look at their elimination status, bowel versus urinary. So these patients are at high risk for constipation. We want to make sure, though, before we even start to give them fluids or food, that they're passing gas and that they have bowel sounds, because these patients are also high risk for what's known as a paralytic ileus, secondary to the anesthesia and the surgery. So we don't want to be giving patients advanced liquids or diets if things aren't moving through. It's going to create a situation that makes the ileus worse. Typically, we might start with clears and advance them all the way up to their baseline diet from at home. We are going to maintain their hydration, at least 14 to 1500 mLs a day, if not more. We're going to encourage the patient to sit in their chair for all their meals, or at least to sit on the side of the bed. This is going to facilitate eating and digestion. And we want to make sure that our patients are comfortable and rested when they're eating, because if they're worn out from therapy or if they're having a lot of pain, chances are they're not going to eat as well as if those things were taken care of. Urinary, like you said, depending on whether the patient has a catheter or they don't when they come out, we want to make sure that patients have adequate urine output. They need to be urinating at least 30 mLs an hour or 240 mLs per 8 hours. Okay? We're going to be assessing for urinary retention in these patients whose catheter has been removed. Like we said, they should urinate within 8 hours. And if given the opportunity, we don't want to delay in taking these catheters out because of catheter-associated UTIs. Pain. For the first 24 to 48 hours, we need to medicate these patients around the clock for good pain control. And usually with surgical procedures, especially the more severe, they're going to have narcotics like morphine, fentanyl, Dilaudid, and they're going to be given IV, usually for the first couple of days until patients start taking foods and liquids by mouth. And then once we know the GI system is working, then we might introduce by mouth narcotics like the oxycodone, the hydrocodone. And again, we are going to introduce non-pharmacological methods in addition to the pharmacological methods for better pain control. So up on the left is a picture of an abdominal binder. These can typically be used for patients who have abdominal surgeries, pelvic surgeries. It can kind of help with the splinting process and help reduce some pain with coughing and ambulation with these patients. The picture down below shows a picture of a patient who's splinting with a pillow while he's coughing. A lot of times patients feel very unstable if they've had surgery within their chest or GI system. They feel like when they're going to cough, they're going to rip apart their sutures. And sometimes they can. So this is a good way to prevent pain and also to enhance security and stability with the suture line. The picture on the right is an example of obviously IV fluids, an IV pump, but it's also a picture of what's known as a PCA, which is known as a patient-controlled analgesic. Some of these patients who need IV pain medication pretty frequently to control their pain might actually have a patient-controlled analgesia, whereas they can actually hit a button every so often to give them a bolus of pain medication. And then they might also have a small dose of a continuous pain medication given to them every hour. And so usually this isn't going to be on long, maybe a day, till they kind of transition a little bit, maybe to where they have that bowel function back. But the difference between this and just a nurse coming in giving an IV push medication is that they need this medication more frequently. So chances are it's a little bit more extensive seriousness of a surgery. The post-op setting, the discharge, as these patients progress through the post-operative phase, we need to start education and planning for discharge on admission. We want to provide adequate amounts of verbal information about the procedure, about medications, about diet, and about their recovery. We want to start, again, before surgery and continue all the way through discharge. We want to include the patient and their family. We also want to make sure that we give them written information in addition to the verbal information. We want to make sure that the written information is geared at a reader of a fifth grade reading level, and we want to make sure it's culturally and spiritually appropriate for everybody. So plan for discharge. We have to consider, are these patients capable of going home? More serious surgeries and patients who are more frail and who have more comorbidities, they may not be okay to go home by themselves. And if they don't have family at home to support them, these patients may be considered more for a rehab or a long-term care facility for a very short duration. So you have to consider, the ADLs and the IADLs for these patients. A lot of times while they're recovering, they might have weight restrictions as far as what they can lift, what they can do, and it's just too exhausting. And the chances of them going home and trying to do this by themselves can result in an injury or an infection, them coming right back into the hospital. So we need to evaluate their family support physically and emotionally. And when we're doing this, we are going to be collaborating with an interdisciplinary team: case managers, social workers, occupational physical therapists, physicians, respiratory therapists, clergy, dietitians, you name it.